It is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Well, just like the man said, that was the immortal Eric Clapton, regarded by many as the one of the best guitarists of all time, especially for those who play the guitar. I'm feeling very mortal today, however. Got a really bad foot. I've been doing a lot of hiking and climbing and not staying on the trails, so I have a hard time walking around today. So it's a good thing I teach online, because I just basically had to roll from my bed to my computer. And even if I could never use my foot again, I could still work forever. This is Dr. Minarcik, I have a big 58 on my cheat sheet today. Some of you may have seen it because sometimes I test my video camera before we start the webinar. It's Tuesday, it's April 9th. We're in Chicago and it's 9 a.m. And for those of you who saw that little video clip, there's not much light around here today. I had to put the light on in the room because usually we have a really bright sunrise as you look at the east window. But now all we have is rain, and it's like the sun never came up yet. I guess it's a good time to do the test for you buzzards. I got the question box popped out already. I'm going to be asking you a couple minor questions here. Can you hear me? That sounds like a good one. Okay, I see yeses. Second question is, what do you see on your screen? Yep, you got that right too. Flamingos. Nice flamingos. Third question is, did you hear the music with high quality? Okay, that means we're ready to rock and roll. Today, I might as well pop out the lab slides. Let me open up my box of slides here. And these are the things that you would be seeing in your slide box as well. If you put the glass slide against your white lab coat. I see everybody has on their white lab coats today. And if you put those slides in back of them, those are the thumbnails of what we'll be looking at. You notice there's an awful lot of cases, so I suspect we'll be taking just about all of the session today, talking about lung pathology, histopathology in lab, looking at some of the salient diagnostic features, and also referring back to as many clinical things that come to my mind. For those of you who saw that little clip of my cheat sheet, at the very bottom there was a big word that said guilt, and let me try to explain that. See, if you were a medical school administrator, you would think because Dr. Minarcik talks for 4 hours a week that he should be paid for 4 hours of work. That's the way those pinheads think. But I want to tell you, for every 2-hour session that I have, I prepare for it 3 hours the day before, and then I spend 5 hours compressing and uploading and modifying the movies for the rest of the day. Sometimes even go until midnight if I'm not pretty fast about it. And I have 3 computers doing it. So it's a lot of work. And it's kind of like a half-time job for an old guy like me. But the thing is now, when we have a lab, I really don't have to do much work at all. I just pull out the slide box like you see here, and I start putting it under my microscope, and then you buzzards are sitting around, I don't know, in a 50, 60, 100-headed microscope and looking at it with me. There's not much by way of things I write down, or basically just looking at slides and showing you histopathology. I know I don't think any of you would ever take a radiology course if you didn't see any x-rays. And I think that it's a shame that there's a lot of medical schools who want to save money. They don't want to hire pathologists or qualified people. And they think students can take a pathology course without looking at slides. Instead, they have them sit around in a room and self-teach themselves and hold hands and talk about what they read the previous night, sometimes in front of a person called a facilitator who never looked at a slide in his life. So welcome to Histopathology Lab. And last comment I want to make is that a couple people have been asking me about Rock Lab already. And I know that Ali has circulated a list to people, and many of you has responded. And so I know there's a few groups now that are getting together. And somebody asked me about the deadline, okay? Now, normally I say the deadline is at the end of the course. And it looks like this course is not going to run much more than about a month. I really doubt if it's going to run into May. But I'll give you a leeway, okay? I will say that by the end of May, this is absolute, no exception now, by the end of May, for those of you that are working on Rock Lab, either with yourselves or groups of people, end of May, May 31st, very last day. If it's June 1st, it doesn't count. So you got a good amount of time now. It seems like it's about 2 months. Get on the cases, and then we'll have our little Skype interview, and then we'll continue to have fun. On our very, very last session, this is our last session for systemic pathology. We're going to have, I don't know, I estimate 4 more sessions for the entire course, but it might be 5 because I'm never good at predicting how much time we're going to take to talk about things. But historically, we should be done in about, 4 more sessions, which means we'll be done way before the end of April. The very last session, however, we will have Dr. Vinay Kumar here. And that's the session that I want everybody to be at. And also, bring your microphones as well. We're going to say hello to him. He loves to hear from you, especially when he's getting questions fired in from all over the world. So those are the only announcements I want to make. We are now in lab. You see we have, is this 40 slides? We got 2 hours to talk about them. And they're all in alphabetical order, so there is no logic to what we're seeing. The only one that I changed its alphabetization structure was the first one, because I think the very first slide we should look at, if we're going to be looking at 39 abnormal lungs, I think we should look at a normal one first, even though you all have seen this one before and possibly in shotgun histology. Let's put the normal lung under the microscope and talk about its salient features. Now, once again, I don't want you to feel like you have to memorize a bunch of names of cells and everything. Just memorize the picture. And basically, there's 2 kinds of holes that you see here. There's air holes and there's blood holes. And of course, the larger blood holes with the thicker walls are pulmonary arteries and their branches. And all the other holes that don't have blood are in probably 99% of the air holes here are alveoli. But you could see things like a bronchi. The reason why I call that a bronchus is I think there's a little piece of cartilage there. Then you can see bronchioles. And as the air holes go from the main stem bronchus to the alveoli, without having to memorize the names of all that epithelium, let's just say it remains simple epithelium, which means 1 layer, but it goes from columnar, in fact, pseudostratified ciliated columnar, maybe with some goblet cells, like you see here. Yeah, see, there's a little piece of cartilage. And then as it goes towards the alveolus, you could probably see that's probably a great alveolus over there. The epithelium gets flatter and flatter. Finally, when you're in an alveolus itself, like we'll look at over here, basically all you're seeing lining that septum are capillaries, like you see there, and there, and there, and there, and there, and there. And most of these other cells are probably type 1 pneumocytes, which technically are the final lining cells of the airways, in very, very intimate relationship with these capillaries over here. So basically you go from bronchus to bronchiole to terminal bronchiole to respiratory bronchiole to alveolar duct, all the way into these fine little things, the alveolus itself. What more do you really want to say? I really don't think I want to say anything more about it. But once again, the best thing to do is to just get a visual picture. And take a look at that nice big pulmonary artery. And notice, yeah, it's filled with blood. But do you notice how the blood is kind of like a mixture of blood and there's no fibrin formation? So, you know, this is not a pulmonary embolism. This is just blood that has been inside the lung. If it were to become a fresh thromboembolism, or even technically a thrombus, but primary thrombi of the pulmonary arteries are very, very rare, you would not have this mixture of reds and whites like in a peripheral smear. You would basically have some layering of the cells, and you would also have some fibrin deposition as well. Look at that beautiful smooth muscle there. I don't know. I don't think I really want to say anything more before we get to the bad guys, but I want you to take a real nice overall view of the good guy here. I guess we could mention that I don't know what part of the lung it is, but this looks kind of like a nice curvy edge here. This could have been a pleural edge. So let's see if we could find some mesothelial cells as well, because we talked about them a lot. I don't know. I think these could be mesothelial cells, a thin layer of sort of spindly mesothelial cells, which are epithelial cells, which are mesodermally derived. That's why they're called mesothelium. And you notice how thin and delicate they are. And we've already said that many of the lymphatics of the lung are concentrated subpleurally. The one thing I don't see in this lung, which you see in many, many lungs, is anthracotic pigment. I told you before, I can't ever imagine, I never saw a lung that didn't have some anthracotic pigment in it. So let's see if we could keep that promise and find a little bit somewhere. They're most rich in the subpleural area. That's why when you look at lungs and your autopsy or dissection table, they look very, very black when you're looking at the visceral pleura here, but when you open them up and cut through them, they're nice and pink. Well, guess what? This guy might have been a farmer, okay? Or I don't know what it was. Maybe it wasn't even a human, but I don't really see much. I don't see any anthracotic pigment here. Okay? Look at these beautiful cells. This is probably one of the nicest lungs you'll ever see. Okay, and look, there's even a little cluster of nice lymphoid cells protecting the integrity of that bronchus there. So how about if we move on? Keep all of that in mind. Here's the first slide. So the professor that I had when I was a medical student, every time he asked a question, he would light his pipe. In other words, when he's lighting his pipe, it means he doesn't want to talk anymore, and he wants somebody else to talk. So right now, I don't smoke, but I'm sipping on my massive cup of coconut coffee. So I'm going to ask you, while I sip it, do you recognize this tissue here in the northeast? You probably heard me swallow the coffee. Yeah, it's normal lung, isn't it? Pretty normal lung. You see a lot of air spaces. You can see some blood vessels. So you know this is lung tissue that we're dealing with. That's the only reason why I asked you. Most of this is some type of fibrous nodule in the lung. You don't know where in the lung. It could be anywhere. I don't really see a clear-cut pleural surface here. But it's some type of fibrous nodule, but it also has clustering of these little peppered, obvious lymphocytes towards the edge, and it has a lot of these little circles everywhere else, especially in the middle, and it looks like there's a lot of fibrous tissue too. And by the way, even at this power, you all know what that real black peppered stuff is over here and around here. That's finally we got our anthracotic pigment. And look at these congested blood vessels over here. So I guess if we made a nice slice into the entire Midwest over here, we would be able to see everything we just talked about in greater power. So that's exactly what we'll do. Here's relatively normal lung. You can see alveolar septae over here. You can see clustering of lymphocytes at the periphery of this fibrous nodule. You can see some prominent blood vessels in it. You can see some more lymphocytes. But I don't think that this is the diagnostic stuff that we want to talk about. The question is, look at this and this and this, all these little holes, all these little circles. And of course, at this stage of the game, I would be amazed if many people here did not recognize this as glands and haphazardly infiltrating glands. And even if we don't look at the nuclei and nucleoli to see that they're big and dark and so forth, we all know that they are growing in a haphazard fashion. So we can suspect malignancy here on the basis of the behavior of these cells rather than the appearance of these cells. Sometimes it's nice to have both, but you don't always have both. You have one or the other. Last but not least, you finally got some anthracotic pigment trapped up in here, which is in probably every lung you've ever seen. Okay, somebody want to take a stab at the diagnosis? I mean, I pretty much have given it to you on a plate over here. Yeah, it's an adenocarcinoma. That's right. And can I ask you another question? These are all glands, obviously, but let's say this was really, really very, very tiny, needle biopsy, and this extreme area here in the northwest. Let's say that this was the only cluster that you saw. Would you say maybe this is squamous cell carcinoma rather than adenocarcinoma? I probably would. I think anybody would be fooled. In fact, if you use your imagination a little bit and imagine there were some little lines crossing these clear spaces, you would be sure. And maybe it is. Maybe this part here is squamous. I'm not saying isn't, because an adenocarcinoma of the lung can have squamous elements, and a squamous cell carcinoma of the lung can have which looks like glandular elements, and an adeno or squamous cell carcinoma of the lung can have elements that look completely undifferentiated, and that's why we call all of this stuff non-small cell. Okay, let's back up a little bit now and go to where the money is. These are your haphazardly infiltrating glands. We already said we suspected they were malignant because of their behavior. But now let's forget about their behavior of doing the crime and just look at their mugshot in the police station. Are they large? Let's say that this cell over here, which my pointer is on, was a 10 micron lymphocyte. Or probably this one is over here. That's better because it's a little rounder. If that nucleus of that small lymphocyte was 10 microns, I'm going to ask you, what is the average diameter of most of these cells? That's a good question. You could give me your best shot. Somebody said 25. I would have probably said 20 to 30, so 25 is a good guess. They're large, they're irregular, and what do many, if not most of them, have in their nucleus as well? A very prominent nucleolus. And of course, those are seen in many adenocarcinomas as a feature as well. So let's just say a very large cell with a prominent nucleolus. Even if it's not forming a gland, perhaps this was in cytology or on needle biopsies, probably suspicious for adenocarcinoma. But we have the additional feature of also recognizing that most of these malignant glands now also form most of these malignant cells also form glands. And we'll travel down a little bit. Glands. Here's the key question now, and we're going to see this coming up again in another case. I'm going to ask you a question. There's only 3 possible answers. Yes, no, or I don't know. Is this adenocarcinoma of the lung primary to the lung or metastatic? I'm sipping my coffee. Most of you people give me the correct, honest answer is I don't know. And that still represents a large diagnostic problem in surgical pathology. A person comes in, there's a coin lesion or a nodule in their lung. They biopsy it. They see it, that's adenocarcinoma. And the patient has no known primary, so they want to know if it's metastasis. And many times now you can do stains and even molecular studies. We attended a conference showing all the molecular studies you could do to prove it's from either the pancreas or the colon or the breast or something like that. But still there represents a quandary as to where it came from or whether it's primary or metastatic. So if without the benefit of a whole battery of special immunochemistry stains or genetic studies, or without any more knowledge about this patient's history, the absolutely correct answer to the question is, I don't know. But let me ask you this. Let's say this was one of 20 little lesions throughout all the lobes of the lung. Then would you think it's way more likely to be metastatic than primary? Right. But if it's just a solitary nodule, it's really kind of a quandary. And usually what they do is when they have a nodule like this and they don't know where the primary is, they start doing a whole bunch of things like GI studies and CT scans just to see if it's, coming from a place that normally gives rise to adenocarcinomas. In other words, glandular organs. Oh, last question on this case is something you may not have noticed, and I was not going to mention it, but it's critically important. Obviously, this is all cancer, right? Cancer in fibrous tissue. But what are these clusters of lymphoid nodules, mostly primary nodules, some secondary nodules? Why are these clusters of lymphoid nodules at the periphery of the lesion? Anybody want to make a wild guess? It's not a scientific answer. It's sort of an anthropoid answer. You're kind of giving a human attribute to a cell. The reason is, yeah, that's right. Somebody got it right away. It's trying to fight the tumor. It's trying to contain the tumor. So here's the question. Let's say that you had two adenocarcinomas like this. One of them was loaded with these lymphoid nodules all the way around, and the other one didn't have any. Everything else being equal, which patient is going to do better? The one where their lymphocytes are fighting the tumor cells like crazy, or the one where there's no soldiers fighting the malignant army? Absolutely. Okay, good. We're done with that case. Let's move on. Here is, now you probably saw, you may have saw the label on this. I wish you wouldn't, because once again, you could instantly recognize this as lung. And once again, you can see that there's some kind of nodule in the lung. And once again, you can see that it's sort of fibrous here in the middle of the nodule. It doesn't look like there's any lymphocytes towards the periphery. But I think even at this power, you're kind of getting the feeling that these are glands again. And I'm going to blow up the north coast over here. And you can see, once again, we got a nodule composed of relatively haphazard but well-contained glands within the lung. And this is by definition, and appearance, another adenocarcinoma. Even if the cells do not look as bad as the other cells, and I'm going to show you some of the nuclear features over here, they look relatively uniform, but the fact is you have a nodule in the lung. It has some fibrous tissue in the middle, and I want to make sure that you know this is fibrous tissue, because I don't want you to mistake this for being central necrosis, okay? This is not necrosis. There's a lot of blood vessels in here. There's a lot of cells. There's a lot of macrophages. Basically, this is a fibrous tissue and blood vessels on the inside. So what's your diagnosis? I'll accept anything reasonable and anything unreasonable too. That's another adeno-CA. And let me ask you another question. Is this primary or is this metastatic? What's the correct answer? Aha, you got it. Somebody, most people are saying don't know. Some people are saying could be primary. Well, actually, it was labeled as metastatic, but that's just because it's on the label. There's no proof of that. In all honesty, if you showed this to my top pathology buddies all over the country, they would have to be honest and say, I don't know. Of course, if you told them the patient had a carcinoma of the pancreas, they would say, oh yeah, this is classical pancreas. If you told them the patient had a classical colon cancer, they would say, oh yeah, this is colon for sure. It's called intellectual dishonesty. But I want to show you something that you probably missed, and the reason why you missed it is because I've been hiding it from you. Okay, so there's your nodule. There's a lot of relatively normal lungs surrounding it. You know, we go through the histology textbook again. There's a perfect little alveoli. Maybe the lung is a little congested. But can I ask you one obvious question, because I've been hiding something here? What's this? What's this? Before you answer, don't answer until I zoom this up a little bit, because I don't want you to make a mistake. I'm going to zoom this thing up, and I'm going to ask you one question. Is this just normal blood inside of a pulmonary artery, or is it a thrombus or a thromboembolism? Ah, you're afraid to answer, aren't you? Yep, most people are getting it right. This is a thrombus or a thromboembolism. Probably an embolism because it's not really adhering that well to the wall. And I want to tell you why, okay? This is a subtle difference. Do you notice how in that last piece of blood that we saw in the pulmonary artery, all of the white cells were generally mixed with the red cells in an equal proportion? Well, in this one, the white cells are starting to take a little bit of clustering. And in addition, what is this pink amorphous stuff here and here? Those are not crushed red cells. That's fibrin. This is a recent thromboembolism too. Now, do thromboemboli, do pulmonary emboli cause cancer? No. Let me just raise the possibility. If this is a metastatic lesion, could that metastasis have traveled with that embolism over there? Well, I guess that's possible, except you don't really see any tumor cells in here, do you? Or is it just an area of thrombosis of a medium-sized pulmonary artery in an area where there just happens to be cancer as well? Those are all the possibilities. I don't know the answer, but I want you to understand this is much more likely to be a recent thrombus with fibrin and segregation of cells, rather than just a piece of fresh blood that happened to be in the pulmonary artery when they cut it. Okay, good. Let's go to the next case. And I don't think anybody was fast enough to see the label on it. That's good. This is one of the easiest recognizable conditions of the lung. It's probably going to be in half your patients that die. You'll probably have it too when you die, most likely. You can see it's lung. You can see there's a lot of congestion in the vessels. But yeah, everybody got the right answer. What is filling up the alveoli in most areas of this lung? Fluid. So what's your diagnosis? Acute pulmonary edema, right? So this is probably heart failure. Maybe acute heart failure. What if this person was in very, very chronic heart failure? Do you think that these congested vessels and the edema might actually result in a lot of those blood cells leaking into the alveoli and being chewed up by macrophages? So here's the question. Is this acute or chronic heart failure? Okay, everybody got that right. I'm very happy. Now, just out of curiosity, does anybody know what else is in this lung that I'm about to show you? Do you know what the real trick is in this one yet? I mean, let's be honest. This is just regular old pulmonary edema. There's no heart failure cells, so it's probably acute. And what I'm going to do is I'm going to go back. And you can see, oh, there's a little cluster of inflammatory cells here and here. So maybe could this be maybe a possible very, very early bronchopneumonia? I don't know, but to have a few clustering of lymphocytes around bronchial areas, it's probably no big thing. Okay. And look there's some anthracosis inside of macrophages. And you know, there's a small blood vessel, and here's a beautiful alveolus, and here's a couple of lymphocytes. How many people feel really, really lucky that there's something in here that I'm not pointing out at 2 o'clock? See that? See that? What is that? What is that? You know what that is? Yeah, you're getting it. Somebody said foreign body, somebody said hyphae, but the first person to respond got it right. Actually, it is a foreign body, and technically it's thin and narrow, so it could be a hyphus. This is what a classical ferruginous body looks like. This is asbestosis. Now, I shouldn't say asbestosis because asbestosis is a disease. And this is probably just an incidental finding in somebody who may have died of acute heart failure. But do you see that little rod, and it's surrounded by macrophages, and there's a smaller rod there, and it looks like it has like a little round club at the end of the rod. And look, there's a little macrophage surrounding that as well. It's probably just an incidental finding. I would not be surprised if we took a look at your lungs or my lung right now. We could probably find a couple of these. If you ever lived near a building in which there was asbestos, probably not of any clinical importance, but it's one of the most beautiful incidental findings you could see. In fact, it's so beautiful, it takes away from the overall picture of acute pulmonary edema. And by the way, whereas most of this is pulmonary edema, if you look in the northwest and in the west, probably on the left side of this, you could say acute pulmonary edema, on the right side. But in the middle and on the left side, you could probably just say congestion, or hyperemia might be another word. So probably congestion is a better word because it's passive due to lack of venous drainage, rather than acutely hyperemic due to increased arterial. Oh, and look at, what do you think we have over here? Wow, I never even noticed this one before, but I think you all know what it is. We could probably sit around and wonder, oh my God, classical multinucleated foreign body type giant cells. And can I ask you something? What kind of foreign body are these giant cells reacting to? What is that little iron-looking type rod again? Yeah, that's in the ferruginous body. And you can tell it's pigmented. It's not quite as red as blood. But if you did a Prussian blue stain, which you do to identify hemosiderin, what color would that be? It would be blue, or greenish blue, wouldn't it? Beautiful case. Nice case. Oh God, I shouldn't stretch myself on the limb, but you remember we said that asteroid bodies inside of giant cells are often seen with sarcoid, but they can be seen in a variety of other things. I'm almost thinking that that almost looks like an asteroid body inside of that multinucleated macrophage as well. Okay, so much for our imagination. Let's move on to the next case. Okay, I don't know what this is. I didn't even look at the label myself, so I guess I'll have to be intellectually honest as well. Well, how many people know it's lung? Of course, everybody does. Oh, it looks like there's some edema in this lung. You know there's edema down here. Maybe there's more than edema over here and over here. Maybe there's some inflammation too. And you can see part of a bronchus there. Some of the epithelium of the bronchiole, rather than bronchus, is thing. So here, let's take a look at the middle portion of this, just to make us a little bit more honest. Yeah, there's edema, but there's also inflammation. Look in this alveolus is filled with inflammatory cells. Otherwise, it's edematous. There's a bronchus. Would anybody object if I called this thing bronchopneumonia, or at least early bronchopneumonia? Because the inflammation seems to be centered around this bronchus, and here's one that's really inflamed. And so you know that when you have bronchopneumonia, there's a wide variety of bacteria and viruses that can cause it, the classical ones. But you know what? I'm also being tricky with you on this case too, because let's go inside of this bigger bronchus here and make a box here in Texas. And here's something inside of a bronchus. And my God, what is that? It doesn't look like anything human inside of a bronchus. And look, there's some inflammation around it. And yep, you got that right. Somebody said, and multiple people said, food. So, what is the specific cause of this bronchopneumonia? Aspiration pneumonia, isn't it? And yes, a wide variety of bacteria could also be secondarily inflame an aspiration pneumonia. And there could be a wide variety of bacteria inside here too. But for the most part, the primary cause of this is aspiration. Maybe the patient was comatose, maybe they lost their gag reflex. If this patient was found, laying down somewhere and brought in and they had pneumonia, maybe they died of pneumonia, what lobe of the lung would this most likely be that we're looking at if he was laying on his back? Probably the posterior or lower lobes. Okay, good. So much for that. I think you're kind of remembering all the stuff we talked about earlier, so let's move on. And this has a specific label on it, but the label is too specific, and it's not fair because what they labeled this as, I don't think you saw the label, is that you can see once again this is lung. Here's some lung up here in the northwest that's just congested and perhaps early inflamed. Here's some alveoli out here and lung tissue in the north that looks like it's just loaded, with inflammatory cells, okay, and fluid and edema. And by the way, if acute pulmonary edema is strictly transudate, what kind of fluid do you think is here in these alveoli with a whopping pneumonia around it? Transudate or exudate? Probably a lot of the stuff is fibrin here, isn't it? Okay. And can I ask you another question? If the inflammation in this lung, the pneumonia, is so severe, like on the top here, you could still see some outline of alveoli, but in the lower portion of the field, you can't even see the outlines of the alveolar septae anymore. They're kind of destroyed. So what would you call this big bag of pus cells here? Call it an abscess. And if it was not big enough to be seen with your eyes as pus, which it could be, then you'd call it a microabscess, wouldn't you? And I'm going to be really, really tricky here, but I got to show you something important, and I think you'll be happy for being tricked. You see this little bronchus here? Or I'm going to ask you an unfair question because we haven't really talked about this yet, but if you use your just common, simple logic, you might be able to figure this out. What's inside that bronchus? Whoops. What's inside that bronchus? See, nobody knows. I didn't expect anybody to know. What's inside that bronchus are cell fragments that are called squames. S-Q-U-A-M-E-S. I'm not saying squamous cells because not many of them have nuclei. But if you were to take the stratum corneum off of the skin and just have squamoid-looking things, you would see something like this. Why would somebody aspirate squames? Ah, you're still silent. What if I told you this was a newborn infant? What's the most common cause of aspiration pneumonia in a newborn infant? Yeah, amniotic fluid. This is amniotic fluid aspiration. Very, very common. Looks like that baby took their first breath a little bit too early, probably while there was still some amniotic fluid surrounding them. Okay, good. Let's move on. And you could see this is the area of the abscess here. Let's go to the next case. We're making some pretty good progress. We saw this next slide already, and I want to go over it briefly. You can see it's lung again. You know this is a bronchus rather than a bronchiole because it has cartilage. You can see some normal-looking alveoli here. You can see a large or medium-sized bronchus over there. You can see that there's a lot of inflammation around it. Okay, here's the question. Of all the bronchi that you've seen in your life, in other words, out of the 10 million that you've seen, does this one look like it has really an abundant amount of peribronchial mucus glands around it? Does it look like this bronchus is really, really, really rich in mucin? Look there's some bronchial glands, there are. And secondly, is it inflamed? And of course it's inflamed. You know, look at all these inflammatory cells here and in the glands. And let me ask you a third question. Do you know how in a normal bronchus you should have a nice little circular layer of smooth muscle? Well, look at, you got smooth muscle fibers going this way and this way and this way. Whoops, I didn't want to do that. See, there's abundant mucin. Look at almost every other cell here is a goblet cell or mucin-looking cell. There's a small artery. You know I'm trying to lead you up to something. So let's get back to where the money is. Let's get to where the actual bronchus is. The bronchus itself is filled with perhaps cellular debris, mucinous material. How many people just want to call this bronchitis? Well, there's no neoplasm here. There's a lot of mucus in reaction to, and there's a lot of inflammation, and there's a lot of smooth muscle hypertrophy. How many you just want to call this chronic bronchitis? Just say yes or no. You want to call it chronic bronchitis? Yeah, I would too. Okay. Now here's the kicker. Let's say if in the process of looking at these cells which are composing the chronic bronchitis, like here, what if 2/3 of these cells were eosinophils? Look, and they are, aren't they? See all that red stuff? See that red stuff? See that red stuff? Some of these may just be lymphocytes, but more than half of the cells here in these inflammatory clusters are eosinophils. And look at how you have hyperplasia of the smooth muscle, abundant mucin, perhaps even mucus plugging. There's certainly a lot of junk inside there. You can't see bronchospasm because that's a clinical term. It's not a pathologic term. You can't hear the wheezing, but you could see perhaps narrowing and inflammation of the bronchi and bronchioles. So here's my final question. If non-allergic asthma has basically the same appearance as chronic bronchitis, but allergic asthma generally is signified by abundance of eosinophils, then the question is, would you prefer to call this allergic or non-allergic asthma? Yeah, that means it's very possible that this patient can have actually source of allergens identified by a variety of tests, or maybe not, but that's the general principle. Okay, so basically it's a chronic bronchitis with a lot of eosinophils, and that by definition is asthma until proven otherwise. And look, there's some nice lung out there. Oh, can I ask you another question? If this chronic bronchitis and mucus plugging and narrowing of the bronchi was long-standing enough, chronic, what do you think would happen ultimately to the alveoli that feed this bronchus or go from the bronchus? What do you think ultimately would happen to these alveoli here? They would become overinflated because of the inability to expire. perhaps where would be wall rupture, and what normally would look like a sponge would now look like an extreme sponge. You would have emphysema or chronic obstructive lung disease. Okay? Next case. None of these are really tricky cases. You know, most of the cases on lung that we're going to look at today are pretty straightforward, and you know, you don't have to have any magical knowledge. You just have to remember what the normal lung looks like, and then you have to say whether it's now infiltrated by inflammatory cells, whether it looks like an extreme sponge, whether there's large glandular or malignant looking cells. So even at low power, can I ask you, is this a degenerative, an inflammatory, or a neoplastic disease of lungs? Inflammatory. Okay. Yeah, I'm getting all the right answers here today. And what about this area down here in Georgia? Or maybe you want to call it Alabama. I don't know. This looks mostly edematous, but for the most part, what is filling up all these alveoli? What are 99% of these cells filling up and perhaps even destroying some of the alveolar septate? These are neutrophils. So this is acute bronchopneumonia. And if it was in an area in which you could say, hey, these alveolar septae are more than just being destroyed. You know, these alveolar septae are gone. You say, well, maybe I could recognize part of one over here, but for the most part, this normal lung is now replaced by a big bag of neutrophils. So we got ourselves an abscess. Okay, last question, I think. Sometimes I always think of more questions, but last question is, it's maybe not an unfair question, but I want you to be a keen observer and say, does it look like these bronchi here have a whopping amount of inflammation in and through them as well? And if you could theorize that the brunt of this inflammation may have started in the bronchus here, then would you think this is probably the most common type of pneumonia, bronchopneumonia, rather than lobar pneumonia? It's a judgment call, I'll admit that, but it looks like this is not, lung is not all uniformly involved with inflammation. In my opinion, I might be biased, it looks like it's kind of clustering up around these bronchi over here. So I think and look, there's a bronchus that's pretty much destroyed as well. So it's a bronchopneumonia with abscess. In fact, we've just described it, and I believe that was also the title of the slide as well, so we happen to agree with them this time. Let's move on as long as we're making a lot of progress here. Remember, none of these are tough. What do you have here? A degeneration of the lung, an inflammation of the lung, or a neoplasm of the lung? Pick one. Okay, I'm seeing a wrong answer. I'm seeing the right answer. Somebody's saying degeneration, but look, aren't really these things inflammatory? Here, let me go up higher power. I don't want to trick anybody. Are these largely inflammatory lesions? Aha, somebody's already got it. Not only is it inflammatory, but the inflammation seems to be clustered in these little balls that looks like they also have multinucleated histiocytes or multinucleated macrophages. So we have a pneumonia, but we also have granulomatous inflammation. And whereas in these smaller granulomas, it looks like you could see outlines of cells even in the center portion of the granuloma, I will admit that when you get to the bigger granulomas, you really don't see outlines of cells in the middle anymore. Instead, you see, here I'll blow this one up, You see necrosis. You see coagulation necrosis. This is not fibrin. This is not fibrous tissue. These are not fibroblasts. This is coagulation necrosis. So we have an inflammatory reaction in the lung. It's largely granulomatous. Very, very often when you see clusters of macrophage-looking cells and their granulomas, you'll see multinucleated giant cells as well. There's one. That's probably part of one. There's a beautiful one. Look how they just go like a nice little circle. So what's your diagnosis? Somebody said TB and somebody said caseation. And caseation is absolutely correct. And TB is without a doubt the most common cause of caseating granulomas. So if you see something like this and you suspect it's TB and maybe already know the patient had TB by history, but let's say you want to prove it anyway. Somebody said it could be sarcoid. Well, it could be, but generally the sarcoid granulomas do not caseate. They can, but usually they don't. They're classically described as non-caseating. What stain would you order on this slide to prove it was tuberculosis? Somebody said acid fast. Anybody want to give? Somebody said Zeal Nielsen. So yeah, you got all that stuff right. Let's move on. Caseating granulomas in the lung. Let's take one more quick look, and you'll see how that's absolutely the correct diagnosis. Okay, next one. We're in the second row already. That's good. I didn't even read the thing on this one, but to me, it looks like this lung, once again, you could tell it's lung. That's the easy one. Oh, you could see that it's congested, to say the least. You can see parts of a bronchus there. You want to just write this off as another bronchopneumonia, or do you want to get fancy? I would probably, without going into the big detailed exam, I would probably just call this a severe congestion of the lung. If I saw a little piece of carrot inside the bronchus, I might call it an early aspiration bronchopneumonia. But I don't think I see a carrot or a celery or an onion. But I do see a lot of cells in the alveolus which are pigmented, golden brown. So do you remember how we saw acute heart failure before? And there was some blood in the alveoli, but mostly transudate. We said, well, what would happen if the stuff inside the alveoli was now broken down blood pigment like hemosiderin? I would call this chronic passive congestion. And these are all hemosiderin-laden macrophages, otherwise known as heart failure cells. Okay? So when you see a lung and it's congested and you see pigment inside of these macrophages, you don't have to think, well, could this pigment be melanin or bile or lipo? You know that it's blood pigment. So this is chronic heart failure. Somebody already wrote it down. I looked at that after I made my own diagnosis. So let's move on, as long as we're making good progress. We'll take a break after this one. Not only can you recognize this as lung instantly, but you could recognize that there's a nice pleural surface. So this was some nice little pleural surface. And by the way, we've talked about mesothelial cells, but we haven't always seen those little buggers that nicely. But when you have something that has a nice pleural surface and a little bit of fibrous tissue underneath it, you know that that's visceral pleura. And this is not the best stain in the world, but you see those nuclei there and there and there and there. Those are mesothelial cells. And look, it even looks like there's probably a second layer of mesothelial cells there. I'll tell you a general principle is that If there was an effusion in this lung for any significant amount of time, even if it was just a pure transudate or heart failure or something, these mesothelial cells tend to get a little bit activated, and they tend to be a little bit plumper and sometimes even double layered. But I'll also tell you this is not the world's best stain, because you can't see much good separation between the cytoplasm and the nucleus. So let's move on to the other part, and maybe we'll get luckier. Theirs looked like maybe a little bit of congestion in the lung. And you can see the alveoli septae are sort of engorged. So this is a congested lung over here. And look, there's even a little bit of edema leaking out there and there. So we got some edema in the lung. We got congested blood vessels. I'm going to try to find the other side of the pleura if I could ever get there. Oh yeah, here's pleura again. But I'm misleading you, and I'm not getting to the big picture. What we really want to see are these little bronchi here that looks like they have little clusters of inflammation around them, like there, and like there, and like there, and like there. So this is a very important slide in my opinion, because everybody loves to use the term bronchopneumonia, especially if they know it's not a classical strep lobar pneumonia. But here you have obvious and acute bronchitis. But can I ask you, is some of that inflammation now starting to leak out into the alveoli surrounding it? So this is a great, great, great example of an early bronchopneumonia. Okay? This may be so early there's even no clinical symptoms yet. But if this were to expand and these congested or edematous alveoli are now loaded with inflammatory cells, like this one is, and they seem to be clustered around the bronchial areas, then that's the classical pathogenesis of any bronchopneumonia. Okay, you've been getting mostly the right answers. You've been working hard. We don't have quite half of these done. Maybe we'll do them all, or I don't know. But we'll take our 10-minute break now, because I see we are at the hour. And then we'll whip through some more cases. And if I am in a quandary between whipping through them too fast and just not looking at certain ones, we'll just skip certain ones. But today will be a completely 100% lab day today. And remember, this may be our last lab of the entire year, because the 2 chapters now that we have left in general pathology don't really have much or any lab, the chapter on environmental and pediatrics. So let's do our mid-halftime music, and we will see you in about 10 minutes.
Somewhere out there, beneath the pale moonlight, someone's thinking of me and loving me tonight. Somewhere out there, someone singing a prayer that we'll find one another in that big somewhere out there. And even though I know how very far apart we are, it helps to think we might be wishing on the same bright star. And when the night wind starts to sing a lonesome lullaby, it helps to think we're sleeping underneath the same big sky. And even though I know how very far apart we are, it helps to think we might be wishing on the same bright star.
And when the night wind starts to sing a lonesome lullaby, it helps to think we're sleeping underneath the same big sky. Somewhere out there, if love can see us through, then we'll be together somewhere out there, out where dreams come true.
My pappy said, son, you're gonna drive me to drinking if you don't stop driving that hot rod Lincoln. Have you heard the story of the hot rod race where the Fords and Lincolns were setting the pace? That story is true, I'm here to say I was driving that Model A. It's got a Lincoln motor and it's really souped up. That Model A body makes it look like a pup's. Got 8 cylinders and uses them all. Got overdrive, just won't stall. With a 4-barrel carb and a dual exhaust with 4 living gears, you can really get lost. Got safety tubes, but I ain't scared. The brakes are good, tires fair. Pulled out of San Pedro late one night. The moon and the stars was shining bright. We was driving up a grapevine hill, passing cars like they was standing still. All of a sudden, in the wink of an eye, a Cadillac sedan passed us by and said, boys, it's a mark for me. By then, the taillight was all you could see. Now the fellas had rid me for being behind, so I thought I'd make the Lincoln unwind. Took my foot off the gas and man alive, I shoved it on down into overdrive. Wound it up to 110, my speedometer said that I hit top end. My foot was glued like lead to the floor, that's all there is in there, ain't no more. Now the boys all thought I lost my sense, and telephone poles looked like a picket fence. They said slow down, I see spots, the lines on the road just look like that. To a corner, sideswiped the truck, crossed my fingers just for luck. My fenders was clicking the guardrail post, the guy beside me was white as a ghost. Smoke was coming from out of the back when I started to gain on that Cadillac. Knew I could catch him, I thought I could pass. Don't you know by then we'd be low on gas. They had flames coming from out of the side. Feel the tension, man, what a ride. I said, look out, boys, I got a license to fly. And that caddy pulled over and let us by. Now all of a sudden she started knocking down the dip. She started to rock, and I looked in the mirror. Red light was blinking. The cops was after my hot rod Lincoln. They arrested me and they put me in jail, and they called my pappy to throw my bail. And he said, son, you're gonna drive me to drinking if you don't stop driving that hot rod Lincoln.
I can show you the world, shining, shimmering, splendid. Tell me, princess, now when did you last let your heart Yes, I can open your eyes, take you under my wonder, over sideways and under, on a magic carpet ride, a whole new world, a new fantastic point of view. No one to tell us no, or where to go, or share your own daydreaming. A whole new world, a dazzling place I never knew. But now from way up here, it's crystal clear that now I'm in a whole new world with you. Unbelievable sights, indescribable feeling, soaring, tumbling, freewheeling through an endless diamond sky. A whole new world. Don't you dare close your eyes. 100,000 things to see. It gets better. I'm like a shooting star. I've come so far. I can't go back to where I used to be. With new horizons to pursue, I'll chase them anywhere. There's time to spare. Let me share this whole new world with you. A whole new world, a new fantastic point of view. No one to tell us no, or where to go, or sing how they dream. A whole new world, a surprise. With new horizons to pursue, I'll chase them anywhere. There's time to spare. Anywhere. There's time to spare. This whole new world with you. A whole new world. That's where we'll be. Where we will be. A thrilling change. A wondrous place for you and
A lot of beautiful songs today, and that was one of them. And of course, our last song is going to be the most beautiful. It was submitted to us by one of our students. I really didn't have any big, profound thoughts during the break, other than I should probably let my dog out for a minute. And, you know, I really, really enjoy doing these webinars. It's unbelievable fun, especially for an old-timer like me that has nothing better to do. But even though it's fun, it's a big, long year to teach every aspect of pathology that you think medical students need to know. And you look forward to the end of it as well. And I don't know why people should look forward to the end of something that's fun. Now, I know you look forward to the end of medical school because that's not fun. But I always have in my mind, I do the math and I say, okay, well, we're completely done with systemic path after the next hour anyway, and then we'll just go back and finish up on the two relatively small chapters. And a small chapter we could do in one session. A large chapter takes more than 2 sessions. You know, lung took 4, for example. But we probably can finish the last two chapters in General Path, you know, Dr. Kumar's chapter in environmental and nutritional, and then a pediatric chapter. We could probably do this in 4 sessions, or let's say 2 things. So if you do the math, you can see we'll probably be done with this entire course by the end of April. And then the very last session, we'll have a party. Maybe we'll do some singing and dancing. Maybe we'll do the Harlem Shake. I'll bring Jim Liu here, my boss. We'll bring Mac from Minnesota. We'll bring Dr. Kumar. We'll have another good time again. But this is, I'm kind of looking forward to it. And don't forget, bring your microphones on the last session. In fact, you know, if we really had more time, I would probably ask you to bring your microphones every day. In fact, that sounds like a good poll question to ask right now, because I have felt a little guilty. Here's the question. Are any of you in any way sort of disappointed that you didn't get a chance to speak enough? Now, I know you chat like crazy in the question box, but is there anybody that feels we should spend more time to answering verbal questions? I feel a little guilty about it. That's why I'm asking you. I know that it's probably easier and more convenient to just chat something in there, but I don't know, maybe if I had more time, we would have 5 or 10 minutes for verbal comments as well, even if they're negative. What the hell? Okay, well, I'm not seeing a great response there in the chat box for people that feel they want to hear themselves yak, yak, yak. I guess I'm the only one that has to suffer through, you know, opening my mouth all day. So let's go to lab again and finish up. Maybe we'll get done with these if they're quick. But I think we left off here, so because it's still highlighted. So let's go to the next case, and I think you can see the diagnosis already. Oh, and by the way, do you see how in almost all of these lungs here, you could get a general feeling for how lucent they are? Like the normal lung is pretty clear. The congested lungs and pneumonia lungs are denser because they're infiltrated, so they're not only radiologically denser, but they're denser in color on the slide as well. Isn't that interesting? But look at the one we call emphysema. Do you see how it's less dense? It's hypercrepitant. It's hyperlucent. And that's really a good tip, that now whatever looks lighter than normal, if this is normal and that looks lighter than normal because there's more bigger air holes, then it's probably going to be more lucent on X-ray as well. And we've been into this, and we'll say it again. This is the generic word emphysema. It's an adjective. It's kind of a diagnosis. It's generally synonymous with the entity we talked about called chronic obstructive lung disease. And I think now that you've seen a million lungs, I think you could say the one thing about this is that some of these alveoli look like there's no septum between them. Maybe they're hyperventilated, maybe there's alveolar rupture. Now, the process of emphysema is not just mechanical, you know, and due to the chronic lack of being able to empty those alveoli, some of them, the septae actually rupture because of the wheezing and the obstruction at the bronchial and bronchiolar level. There's also physiologic things that come into place, you know, macrophages, you know, being activated and so forth. But the best visualization for emphysema is a geometric, logical one. It's not fancy medical. You have chronic bronchitis, and because of that inability to expire completely, increase in FEV1, you now have overexpanded, overventilated alveoli, alveolar rupture, maybe this one the beginning of a small bleb, or what we call a bulla. And in addition, you're seeing some of the features of chronic lung disease, which are also very common, is that I think I could convince you that not only are these bronchi inflamed, but maybe some of the lung parenchyma around them is becoming inflamed too. So this is chronic lung disease, otherwise known as emphysema, with chronic bronchitis. And if you wanted to add early, perhaps even subclinical bronchopneumonia, you could do that as well. Does everybody remember the two most likely bacteria to cause pneumonia in chronic lung patients? Remember we said staph and strep are always possible anywhere, but there's two gram-negatives that are always at the top of the list. And of course, one of them is Pseudomonas, and the other one is Moraxella. Okay, so you don't see the bugs, but if they are here, most likely it's one of those two. Haemophilus, possibly, absolutely. In fact, wait a minute, hold on for a second. I'm going to go back. I think I made a verbal typo. I meant to say Haemophilus, and instead I said Pseudomonas. So I screwed up. And when I hear myself screwing up when I watch these movies, I cringe. And that's why I don't like watching the movies so much. So classical COPD, all the features right there in one field, and we could move on now. How about the next one? And you could see it's a lung, and you can see some bronchial lining over there. You can also see a lot of cartilage. You don't see too much by way of alveoli and stuff because you don't see, most of what you see here is what looks like bronchial cartilage, but the bronchial cartilage and the bronchial respiratory epithelium is really abundant in the bronchial lymphatic nodules. Well, somebody said hamartoma, and that's not fair because technically the definition of a hamartoma is an overgrowth of normal tissue. Now, the lung has a lot of normal tissue. It has normal epithelium, it has normal lymph nodes, it has normal bronchi, but most of the time when you hear that a patient has a hamartoma of the lung, even though theoretically it could be a benign overgrowth of anything, and most people do not regard these as true neoplasms, most of the time they're cartilage. So when you have a tumor of the lung and you cut through it after the surgeon has taken it out and it cuts exactly like cartilage, and then you look at it and you know this is all slam dunk, quick knee-jerk reflex recognition of cartilage. I don't have to go into the, lacunae and chondrocytes, that this is a hamartoma. Make a long story short, most hamartomas of the lung have chiefly cartilage as their main component. Oh, there might be some smooth muscle. There might be some bronchial epithelium. We even saw some lymphoid cells. Look, you could even see some fat as well, can't you? Chief component, usually cartilage. So we think lung hamartoma, think cartilage. Hamartoma somewhere else might not be cartilage. You can't have a cartilaginous hamartoma of an organ that normally doesn't have cartilage, can you? Because a hamartoma is defined as an overgrowth of normal indigenous cells. Here's another lung. You could see that right away. You could see alveoli there, the entire west coast. But right about the point where you have the Rocky Mountains or Mississippi River, you now have some type of tissue which looks like it's entirely red. It looks like it's entirely hemorrhagic. You can see a pleura here at the bottom. You see the pleura. And do you see how there's pleura along here too? So whatever this hemorrhagic nodule is, you could say pleural based or extends to pleura. And why don't we take a nice square here to include both the normal and the abnormal part of the lung? There's normal on the left, perhaps some hemosiderin, some macrophages inside of alveoli. But look, in this portion of the lung, it looks like the architecture, this alveolar bronchial vascular architecture, is now hemorrhagic coagulation necrosis. It's not tumor, okay? So, can I ask you a question? What if this hemorrhagic nodule in which you have necrosis obliterating obliterating the normal structure of the lung was palpated early in the peripheral portions of the lung, subpleural. This is the world's easiest diagnosis, folks, and I want you to tell me what it is. This is an infarct. Okay? Now, somebody said this is a mesothelioma. I'm thinking about this. Well, a mesothelioma is also pleural-based, but usually in a mesothelioma, you see cells. You don't just see hemorrhagic necrosis. Now, why would an infarct of the lung not usually happen when you have a pulmonary embolism? The reason is because the lung has a dual blood supply. So if you cut off one, the pulmonary circulation, you still have blood flow through the bronchial circulation. It doesn't infarct. But when it does infarct, you usually have compromise of both the pulmonary as well as the bronchial. And most pathologists that are looking for pulmonary infarcts, they could probably have blindfolds on when they're doing autopsies, because you always palpate the pleural surface of the lung, almost with your eyes closed, and look for nodules. And if it's a hemorrhagic nodule, most likely it's an infarct. And what else do we want to say? Oh yeah, what is another organ that has a dual blood supply that usually or rarely infarcts as well? The liver, yeah. Hey, what about organs like spleen, organs like kidneys that don't have a dual blood supply? They have end arteries. Do you think that those would infarct much more readily than organs that have a dual blood supply? Yeah. And secondly, when they do infarct, if you do have an infarct of an organ that has a single blood supply and there's no longer blood, do you think the infarct would be hemorrhagic or white? Yeah, that's right. They call them anemic infarcts. So that's the general principle. Dual blood supply, rare infarcts, but when they infarct, they're hemorrhagic. Single blood supply, much easier to infarct, and the infarcts are what they call pale or anemic infarcts, in which you would have perhaps a coagulation necrosis rather than a hemorrhagic necrosis like you see over here. And you know what? I'm really determined to show you a couple of nice, beautiful mesothelial cells. So we're going to zoom in on the bottom here, and maybe we'll find one. Oh, that's probably one over there. That's probably one over there. They can be very subtle, and very often you miss them because you don't happen to be cutting through the nucleus. So maybe we'll find a nice few mesothelial cells somewhere else. Next case. Don't get fancy about this case, okay? You know it's a lung. You could see bronchi. You could see large blood vessels. You know that it's not normal because you don't have that nice thin nature to it. But you do see in most of this lung there is an increase of cells. Now let me ask you this. Is the increase in these inflammatory cells in the septum? Or are they pouring out into the alveoli with normal thickness of septa? Yeah, so this is a pneumonia. This is a diffuse process, and it is primarily involving the alveolar septae and is doing very little by way of pouring out inflammatory cells into the alveolus. And it looks like most of the inflammatory cells infiltrating the septum are sort of like lymphocytes, maybe macrophages. So don't get fancy. What the type of pneumonia is this? A couple of you already said it, but say it again. Yeah, it's interstitial pneumonia. Is an interstitial pneumonia more likely to be caused by a common bacteria or a virus? In general, yeah, most viral pneumonias start out as interstitial pneumonias. Can I ask you this? If this is an interstitial inflammatory process, could it theoretically progress to interstitial fibrosis if it doesn't resolve properly? Okay, good. Those are all the principles, and you got them right. So let's go to the next case. Oh, once again, you know this is lung. You can see, oh, I don't know if that's it looks like it's an artery. It could be a bronchus. I'll look a little bit more. Here's some bronchus up here because you can see epithelial lining. So that's probably a pulmonary artery. You can see there's general thickening of the pleura. And you can also see that there is an increased density in general. So here's the question. We saw the classical bacterial pneumonias. We saw a classical interstitial pneumonia. Now, is the primary pathologic process in this lung, is it alveolar or is it interstitial? Yep. And does it look like it's inflammation in the interstitium, or does it look like it's the sequelae of inflammation or fibrosis? Yep, you got it right. This is interstitial fibrosis. Remember, we talked about it. We called it idiopathic, and even though we said any diffuse chronic inflammatory interstitial process could result in this, most cases of your classical pulmonary fibrosis are idiopathic. That means that they have a cause, we just don't know what it is, or it could be a wide variety of things. And just to make things a little bit more convincing for you, I'm going to take another higher power. Oh, maybe go about here, you know. And do you see how much fibrous tissue there is now in these alveoli? It looks like there's more scar here than there actually is air spaces, isn't it? So these are fibrotic lungs. It's diffuse. And if you just want to call this diffuse pulmonary fibrosis or interstitial fibrosis, or you could. And we're not going to say anything more about it. Next case. Oh, you're going to love this case. Oh, let's wait for my mouse pointer to calm down. It's lung. You can see pleura along here. And you can see some pleural thickening as well. And you can see some lung here, and you can see some lung at the bottom. Okay, you're probably all bored at this stage. And you're probably saying, oh, God, why is Dr. Minarcik just showing us another stupid bacterial pneumonia again? We could see leukocytes pouring out into the alveoli, so we know this is a bacterial pneumonia. What's the big deal? Well, I'll tell you what the big deal is. I did not plan to trick you on this case. But what if I was to tell you that this was a lobe of lung? And you know it is, because you can see that it has a nice pleural surface here. But look, the adjacent lobe of lung has absolutely no inflammation whatsoever. Whereas the lobe of lung on the other side of this fissure is solidly packed. So here's the question. Is this a lobar pneumonia, or is this a bronchopneumonia? Okay, and what's the most common cause of a lobar pneumonia? There could be a lot of things, but what is it most of the time? Yeah, pneumo or streptococcus, whatever you want to call it. So if you're to do a culture or a gram stain, you would see the little gram-positive balls, maybe in pairs, all throughout here. A good chance your blood cultures would be positive. Okay, and we'll move on. Oh, you know what? As long as we're searching for mesothelial cells, we're not going to find good ones here, so let's move on. I'm going to get you some good ones one way or another. Okay. You know this is lung. Here's a bronchus, here's a bronchus, here's a big artery, here's a smaller bronchiole. You could tell it's diffusely infiltrated by some kind of inflammatory cell. So let me ask anybody this question who knows the geography of the United States. Which state should we go to for a bigger view? Just type in, your favorite state, or where you live, or where you want to go, or which one you hate the most. Washington, good choice. So you could see that, is this primarily infiltrates into the septum, or is this primarily outpouring of inflammatory cells into the alveoli? That's the first question. Yeah, well, most people are saying septum, and that's it, because most of the alveoli here, whereas they're obliterated, most of the thickening and inflammation is in the septum, but there is some alveolar stuff. What's the other crazy thing that you notice? So it's probably a viral pneumonia. Okay, let's go so far as say it's probably viral. But what is the craziest thing that you see here? You're probably wondering what all these big cells are, right? So let's look at some of these big cells. Oh my God. Why would you be getting all these multinucleated giant cells, but they're not really part of a granulomatous inflammation? Looks like they're all over the place. That's interesting, isn't it? Well, this is something that you will never see in your life. And actually, I never saw this during my life either. This is measles pneumonia. This is what killed most of the people that died of measles a few generations ago when I was a kid. Every now and then you hear somebody with measles that just doesn't, everybody in the world had measles, but a small percentage of those people didn't get better. They got worse. They got pneumonia. And this is a measles pneumonia. It's viral. And the measles virus causes these multinucleated giant cells as well. Now, I got to tell you something about this. In every time in this course in which we have seen multinucleated giant cells, whether they were osteoclasts, whether they were part of granulomas, I always said, these are macrophages, these are macrophages, these are macrophages. The giant cells of measles, however, are fused bronchial epithelial cells. They're not macrophages. So that's the big difference. Otherwise, you would say typical multinucleated macrophage giant cell. Okay, and you can see a lot of other inflammatory cells here. Are the primary inflammatory cells look like they're lymphocytes or neutrophils? Yeah, everybody's saying lymphocytes, and that's because most viral pneumonias are not only interstitial, but they're usually lymphocytic or mononuclear. Even if they're acute clinically, they have the so-called chronic inflammatory cells pathologically. Here's another lung. And you can see it's pretty good, nice and spongy, blood vessels, nice air in the alveoli. The thing that, of course, causes you to wonder is I know that your attention is already on the East Coast here. And you can see there's not only thickening of the pleura, but it looks like there's some type of little, almost like a papillary little growth. I don't know, let's look at it before we start using words. Yeah, you could see not only is the mesothelial cells beautifully lining the surface here, but it's even growing in like a papillary fashion. So what's your diagnosis? Yeah, it's a mesothelioma, absolutely. Now, could this be a metastatic or even primary adenocarcinoma? Well, purely on the appearance alone, you would say, yeah, it could be, because I look at their little papillary or glandular structures. But I want to show you something interesting here. What I want to show you is that the cells that comprise this sort of glandular-looking tumor also have the same exact appearance of these nice palisading mesothelial cells that line the lung. So you already know this is probably a mesothelioma that has a glandular or sort of a papillary feature rather than a primary or a secondary adenocarcinoma. Let's say that you wanted to waste a lot of the patient's money and make a lot of money for your hospital administrator or your lab, so you order a bunch of special stains to prove that this is a mesothelioma rather than an adenocarcinoma. Do you remember the name of the special antigen that's present on mesothelial cells, but it's not present on adenocarcinoma cells. We talked about it. Yeah, it's a protein, all right. We called it calretinin, remember? And a calretinin immunohistochemistry stain would be positive if this was a mesothelial cell tumor, which we think it is. Now, what if we did, for example, a electron microscopy on these tumor cells? Here, let's blow these up. We got them really blown up. How would these tumor cell look different on electron microscopy if they were mesothelial cells rather than adenocarcinoma cells? Generally speaking, mesothelial cells and even most mesothelial cell tumors are extremely loaded with microvilli. Remember, we have to have maximum surface area on that one single lining cell. So if you were to put these under the electron microscope and they have much more microvilli than your usual, poor microvilli on adenocarcinoma cells, that's another way you could waste your patient's money, is by doing, or insurance money, that's by doing electron microscopy. Here's another lung. Excuse me. It doesn't look too bad. Here's a bronchus. Here's a bronchus. Some alveoli. Oh, maybe some of these alveoli look a little bit hyperexpanded. Sometimes you can describe, or you could use the word emphysematous changes. In other words, you theorize that a lot of these alveoli are bigger than they should be, so you could call that emphysematous changes just as a description or as an adjective without actually having to label this patient as chronic obstructive lung disease. So let's look at some of these bronchi here. Okay, well, I don't know. What's that blue stuff, by the way? You see it there, you see it there, you see it there, you see it there, you see it there. What's all that blue stuff in the lung? Anybody want to guess? There's some blue stuff. There's a mild blue stuff. Oh, there's not much around there. Oh, there's some around there. I'm going to find an area for you until you absolutely know what I'm talking about. I'm going to find you something really perfect where you cannot any longer not know what this is. I'm going to blow up this one blue area here. What is this? Yeah, everybody's saying it now. Calcification. It looks like there's multiple areas on this lung that are calcified. Now, you know that calcium can occur in association or sequelae of chronic inflammation and fibrosis in any inflammatory or even degenerative state. So we got multiple calcifications, chiefly peribronchial in the lung. We know that the cartilage shouldn't calcify. We also know this is not the cartilage here. And I think I'm a little bit tricking you on this case because remember, we said that whenever you have a lot of calcium plating out various organs, lung is no exception, probably the patient may have hypercalcemia. So, do you remember the concept of dystrophic versus metastatic calcification? Is this dystrophic or metastatic? Dystrophic would be if there was one specific localized disease process in which calcium changes followed it. Metastatic calcification is because there's hypercalcemia. Well, when you get all of this calcium depositing multiple areas of the lung, you probably think this patient was hypercalcemic. So that's really interesting because you're looking at a piece of lung here and you could say, I wonder if this patient has a parathyroid adenoma. Isn't that interesting? You're looking at a lung and you're making a presumptive diagnosis about the parathyroid gland. That's one of the beauties of pathology. It all just kind of fits in, and it's logical. Okay, here's another case. And I think, well, most of this is just a big pink ball of nothing, but I think at the periphery of it, you can see that there is some lung tissue. So there we go. You know that's normal lung. There's some clusters of lymphocytes at the edge of this big pink ball. Now, somebody's already got the diagnosis, but I'm not going to tell you what it is, because I want to tell you that this big pink ball, remember, we saw stuff today, other big pink balls, and we looked inside of it and we said, is this fibrin? Is this necrosis? Or is this collagen? So I know it's a tough call because it's all relatively pink, but can I ask you, what is this pink stuff? Well, it's not fibrin, okay? There's no association with acute inflammation. I think, in my opinion, some of it doesn't look like you can see outlines of cells very well. I might go with coagulation necrosis, but I also see that a lot of these cells look like they are viable enough maybe to pick up some of this anthracotic junk. Maybe it's a combination of both fibrosis and necrosis. And at the edge of it, you could see we got some lymphocytes. Now, what do you call a nodule that maybe might be necrotic, or maybe some non-neoplastic inflammatory or fibrotic lesion, and you got lymphocytes? Yeah, this is a granuloma. Now, here's the question. Do you think this is an active granuloma, or you think this is an old granuloma that might be many, many years old? That's right. The older a granuloma gets, the more it's likely to not only fibrose in the middle, but even calcify. And remember, we saw that with the granulomas of the fungal lung diseases. So, let's say that you saw this granuloma, you cut it open, you got it from the surgeon, or you're doing an autopsy, and you go, you know what? I wonder if this patient has acid-fast bacilli inside of here. So you do your acid-fast bacilli, or Zeal-Nielsen stain. Is it likely to be positive or negative? With an old granuloma likely to still show the organisms? Yeah, it's most likely going to be negative. Does that mean it's not TB? No. It means it could be TB, but now it's inactive, and all you got is a big scarred granuloma. It's a pretty big granuloma, too, isn't it? Okay, I think we demonstrated that one well. Let's go to another one. Oh, you're going to like this one. We have to show this one. This is a small piece of lung. That's why you won't recognize it, which means it's probably not from an autopsy. Maybe it's just from a biopsy. And you can see there's some infiltrates there that look kind of red, and you can see there's some infiltrates here. And I'm going to go a step further and at least show you that this is at least lung, right? You can see alveoli, you can see alveolar septae. Here is a perfectly intact alveolus here. What's that red junk that's inside most of these alveoli? Does it look like neutrophils? Does it look like fibrin? Does it look like amyloid? Does it look like calcium? Or let's say that you weren't in the medical field and you were a 3-year-old kid, and I said, what does that fuzzy stuff look like inside of the alveolus? And the 3-year-old kid would say, it looks woolly, you know, just like my pajamas. So you have woolly, fluffy exudates. They're not cells inside of alveoli. And that is what really most of this thing is, no matter where we go. It's just nothing but woolly, cotton wool exudates of these foamy looking material. And I want you to do me a favor And I want you to take a look at this piece of woolly, fuzzy, fluffy, pinkish alveolar exudate. Especially take a look at the parts that have the holes. Take a look at those white areas. Look real hard for 3 seconds. Because we just did a silver stain on them now. Those white holes now stain very intensely with the black silver stain. So what's your diagnosis? Come on, you all know it. For those of you, yeah, this is PCP. This is pneumocystis carinii. This is the main type of pneumonia or immunocompromised or AIDS patients. You know, an AIDS patient that comes in with a pneumonia and has what the radiologist would call fluffy or woolly exudates is pneumocystis until proven otherwise. And even though pneumocystis technically is regarded as a protozoan phylogenetically, it has a lot of similarities to the fungi. And as you know, the fungi take up the silver stains very intensely. So if you would describe these little black balls, which wound up being just clear on those pink slides, as being like a bunch of bent coins, that's how a lot of people describe these. This is new PCP pneumonia. I'll always say pneumocystis carinii. That's the C in PCP. But now the microbiologists change it to Gerovicii. Next case is easy as can be. I almost feel like saying nothing on this case, and I want you to give me the diagnosis. In fact, that's what I'm going to do. Yeah, everybody got it. One person got it anyway. Come on, I want to hear more quick answers. You all know the diagnosis. Yeah, everybody's saying embolism, embolism. Okay, look. Here's the question. Here's a pulmonary artery. It's distended with red junk. Now, is this just regular blood, or is the blood starting to organize into little fibrin lines and crushed red cells, and maybe even the inflammatory cells are starting to line up? So is this clot here a pre-mortem blood clot or a post-mortem blood clot? Pre-mortem, right? Because, and it also adheres to the wall. That's the big thing, okay? So this patient may very well have died of this rather than it just being found as an incidental finding after he died of something else, you know, like a bullet wound or something. Okay, that was just a quick demonstration. Classical. Oh, no, I'll ask you one more question. Let's say we could put 3 adjectives inside of the word clot or thromboembolism or thrombus. One is recent, one of them is organizing, and one of them is old. Which is the correct of the 3 adjectives for this one? Recent, organizing, or old? Aha, well, I got one person that says it's mixed between recent and organizing. That's probably the best answer. I would think the presence of a lot of fibrin would make you lean in the recent direction, but the presence of cells coming in, maybe even macrophages, I would go somewhere between recent and organizing, but I would lean more towards recent, okay? And possibly whatever caused those changes in the thrombus occurred even before that thing lodged in the lungs. Okay, let's see if my mouse pointer here, if the hourglass wants to stop, and we'll look at a few more cases. Here we go. You know it's lung. You can see some lung in the northeast. You can see this is a bronchus. You can see bronchial cartilage. Probably a pretty big one because the cartilage is pretty big. And it looks like there's some type of irregularity in the mucosa of this bronchus. So let's take a look at it. You can see here's that piece of cartilage again. Here is something going on. And look, can I show you something real interesting here? Whatever that irregularity is along the mucosa of the bronchus, can I suggest maybe it's even invading into the cartilage? Do you think a benign inflammatory process can invade into bronchial cartilage? And here I'll go even bigger, because you've seen this so many times, time and time and time again. This is a classical squamous cell carcinoma, isn't it? Don't these cells look squamoid? Plus, it's occurring inside of a bronchus. Most of the cancers that occur in a bronchus are squamous, in the large bronchus. Secondly, it's invading cartilage. And last but not least, I didn't prepare for this last night, but I'm guessing that do you see a lot of these little spaces between the adjacent cells, like there and there and there? Do you see those tiny little hairs that cross those spaces? Those are intracellular bridges. That's a squamous cell carcinoma of the lung. Is a squamous cell carcinoma of the lung, by virtue of it occurring in larger bronchi, do you think it's more likely to be centrally located, or mediastinal aspect, or hilar, or peripherally? You know, there is no cartilage on the periphery of the lung. So yeah, these are all generally more central. Oh, let's look at another one. I think we're making some pretty good progress here. Here's another bronchus. You can see a lot of cartilage. You can see some blood. Oh, you can see some mucosal, submucosal mucus glands in this thing. You can see a nice lining here. Here, let's take a look at this upper portion, and what can you say about it? You can say, well, there's cartilage, there's submucosal, and there's beautiful ciliated, pseudostratified columnar epithelium with occasional goblet cells. That's the classical histologic description for the world's most normal bronchus. There's some smooth muscle. So why am I showing you a normal bronchus? Okay, well, let's try to figure out why I would trick you. Let's go back down now to the other side of the bronchus. You see there's still some cartilage there. And here, let's start out all the way here on the west and blow this up. And just say, yeah, there we go. Pseudostratified, ciliated, columnar epithelium, occasional goblet cells. There's a goblet cell, there's a goblet cell, there's a goblet. Plus there's mucus cells in the submucosa. So why is Dr. Minarcik wasting our time? Well, let's follow this bronchial epithelium down. Now it's no longer simple columnar or pseudostratified. Now you have definite layers. What's the process by which these layered are, now you have, yeah, squamous metaplasia. Thank you. So now we got squamous metaplasia. That's great. So why is Dr. Minarcik showing us this boring case of squamous metaplasia? We know it's common. Hey, oh my God, look at some of this squamous metaplasia now has big, dark, ugly cells, doesn't it? So not only do we have squamous metaplasia, but we have squamous dysplasia. Look at, there's a dark cell, there's a dark cell. These are atypical cells, can't you tell that? And in addition, do you see in this field that we have a, what looks like a duct of this mucus gland? It looks like these metaplastic and atypical cells have also invaded, or I don't want to use the word invaded, but they involve, or they go into the submucosal gland ducts as well. Final question, and I'm going to sip my coffee and make you do the talking. Final question. Would you call this atypia or dysplasia? Would you call this mild, moderate, or severe? Everybody's saying severe. So one person said moderate. Most of them are saying severe. Now, here's my final question. Now, what is the difference between severe squamous metaplastic dysplasia of a bronchus and carcinoma in situ? What is the difference between severe dysplasia and carcinoma in situ? What's the difference? Nothing. So that's the correct answer. As long as this basement membrane here is not breached, it doesn't matter whether this is severe dysplasia or carcinoma in situ. Once it's breached, you now have a potentially metastasizing killer. And by the way, don't be fooled, because when we looked at this thing over here, it looked like it might have been infiltrating, but it's really not infiltrating, because look, there's actual duct, excuse me, there's the actual duct right there of a mucus gland. So this is just traveling into the duct. It's not invading into the fibrous tissue. Okay, good. Next one. Sorry I keep coughing, but you know, us older guys got to have reasons to do stuff like that. Here's a lung, and you can see that there's some type of inflammatory lesion, and it appears to be a nodular pattern of inflammation. And look at, there's also some emphysematous changes. You see some ruptured alveolar walls. And let's take a look at one of these little sort of nodules of inflammatory cells. What's a nodule of inflammatory cells called, especially if it's primarily macrophages? It's called granulomas, isn't it? There's some lymphocytes on the outside. I don't know. You want to see if we could find a multinucleated giant cell just to feel more confident that this is a granuloma? Yeah, so let's make it a little bigger. I don't know. I don't see any good ones. That might be one down here. But here's the question. Just out of curiosity, would you say that the inside of this granuloma is necrotic or fibrotic? Yeah, fibrotic, because you can see that you can still see the outlines of cells. It's not coagulation necrosis. And here's a second question. Do you have to have multinucleated giant cells to call something a granuloma? No. Somebody said yes, but the answer is no. The reason why the person that said yes is because you usually see multinucleated giant cells with granulomas, but you don't have to see them. When you see something that is this classical, you may find them eventually if you look around enough, but you don't have to have them. But nevertheless, I think I'll find you one anyway. If you believe me, I think this is probably one down here. Oh no, on second thought, I think that's a blood vessel. I changed my mind. But if you want to find some multinucleated giant cells, how about if we look at this one here? Whoops. Let's go down a little bit. It's starting to pixelate. Folks, would you call that a multinucleated giant cell, yes or no? I just want your opinion. There is no right answer. I'd probably call it one, especially if I saw more classical ones. So we got non-caseating, fibrotic granulomas throughout the lung. That's the correct diagnosis. What if this was negative for all types of culture, fungi, TB, aerobic, anaerobic? Would you consider the possibility of sarcoid then? Yeah, I would too. In this case, though, the case was labeled as silicosis. This is an occupational lung disease. This is a pneumoconiosis. So you don't see silicon. There is no classical appearance for silicon in normal human tissues. You could probably do an assay for it chemically, But these granulomas are in reaction to silicon particles or silicon material. Okay, silicon dust. Let's see if we're done with this case, or if I want to say anything else. Oh, I don't know. Let's, as long as we were looking, let's find some classical multinucleated giant cells, just to make sure that the other one that we saw was really one. Oh, that's probably nothing. That could be one up there. I don't want to waste too much more time on this. Oh, there we go. Any doubt? Isn't this one of your classical multinucleated giant cells here? In fact, it has some anthracosis in it. Could some of those also have silicon in there? Remembering that silicon does not have a diagnostic or characteristic appearance. Yeah, those are multinucleated giant cells. Next case. Somebody asked, could silicosis predispose to TB? Well, I'm sure there's a statistical relation. I would not say it's a strongly predisposes, but let's say any chronically damaged lung would be more likely to pick up TB in general. So a lot of these chronic lung diseases have a much higher association with tuberculosis. You wouldn't believe this was lung because there's nothing on here that looks like normal lung tissue. But what if I told you this was from the lung? Okay. Well, the first thing you would think is, well, maybe it's a lung tumor. The second thing you might think is, well, whatever the tumor is, it looks like the nuclei are pretty small. Okay? And the third thing you would think is, well, you know, lymphocytes have small nuclei with minimal cytoplasm. Are these just lymphocytes? Well, I don't think you would agree, because a lot of these cells are very atypical. Another thing that these cells do, if you look at this cluster of cells here that have minimal cytoplasm, or the ones over here, or the ones over here, or even the ones over here, do you notice how there is such a prolific growth of these cells that they tend to compress one another? This is called nuclear molding. It means that the tumor cells are growing so fast they're pressing upon their neighbors. And in addition, look, there's an extremely hyperchromatic cell, and so is that. So these are not lymphocytes, but it's small cells, it's growing fast, it's a tumor, and the key thing is these tumor cells are not glandular, they're not squamous, and they're not large. So they look like little oats, don't they? And if they're not large, it means they're small. This is small cell carcinoma, formerly called oat cell carcinoma. And the two things about the cells, even though there's not much to talk about because they're so small and often so crowded, is that they compress each other. That's called nuclear molding. And the other feature about small cell carcinoma, which you don't see in this specimen, unfortunately, is that they have a tendency for necrosis as well. The reason for that is small cell carcinoma is the quickest growing of all lung cancers, and therefore it's the worst behaving. And it grows so fast, very often many parts of it are necrotic, but I will tell you this does not show much necrosis. So remember, small cells from small cell carcinoma, they're small cells, they have molding, they have necrosis, and they're certainly not lymphocytes. Small cell carcinoma. I'm going to show you something else as well in the next case. We have another piece of lung now. Now you know this is lung, and it's just not part of a big tumor. And now you have a pleural, which looks like it's pretty thick and also infiltrated with some type of cell. And I'm going to blow up those cells. Again, we could do it here, or we could do it here. I don't really care. Now here's the question, folks. Are the nuclei very small? Of course they are. Do the nuclei show molding, compression of their neighbors? It's so highly dense in cells. Yeah, this is also a small cell as well. Now, because of the way you see it in the slide here, it may well be a satellite lesion from a bigger small cell. But remember, these are very, very quickly growing. Look at, in this little area here, it looks like you have like a cluster of small cells. Let's take a look at it. And I doubt if this is going to form a gland. But the one thing that you do see here is, oh, I was going to say yeah, you do see necrosis. Look at, see all this area here? These are necrotic cells. And these are your small cells, okay? Small cell carcinoma behaves so badly and grows so rapidly is that most people that have the diagnosis of it, if they're untreated, they have the worst prognosis of all. If they are treated with the more modern chemotherapy regimens, they have a very, very good chance that they could respond drastically. I wouldn't want to use the cure word, but they classically often have very, very good responses to chemo. But in general, the tumor is so fastly growing. Here, let me give you an example. Let's go back down. Do you think that if you were to cut open this lung, you would say this is definitely tumor here? Or would you just say, oh, it's just a little thickening of the pleura? Well, they often spread so early microscopically that patients that have small cell carcinoma often get prophylactic brain radiation, because even though they cannot see the tumor cells by CT or any other MRI, statistically, most likely they're there. So that's how quickly growing it is. The worst prognosis, untreated, of all the common types of lung cancer. Next case. Another slide. I think you could see lung here. Oh, I think you could see, oh, maybe some fibrous tissue here. Maybe some more fibrous or inflammatory tissue here. And I think I showed you this case as a still slide, but I'm going to zoom in here on the whole southwest. And I'll ask you the question again. Is this a degenerative, inflammatory, or neoplastic lesion? Yes, inflammation is correct. Is the primary inflammatory mode intraalveolar or relatively normal, thickened septae and mostly inflamed alveoli? It's primarily an alveolar inflammation, isn't it? So this is probably a bacterial pneumonia. There's nothing fancy about this, but this slide was labeled abscess, okay? So whereas in this portion of the inflamed lung, you can still clearly make out alveoli and the septae between them, what about this portion of the lung here, on this side of the little fibrous membrane? Can you, if I was to zoom in and just draw a little box right here, for example, in Oklahoma, can you really say with a high degree of certainty that there is still an alveolar framework in there, or does it just look like a big bag of pus? So you know this is a abscess or microabscess if you couldn't see the pus grossly. Yeah. So this was just called, you know, pneumonia with abscess. I'm not, you know, getting fancy. As we've seen it before, we'll probably see it again. Here's some more lung. Here's some more pneumonia. I'm going to show you something really cool here. Okay, here is some, I would say, mildly emphysematous lung, but there's pneumonia up there. And now you got the pleural surface. And look, normally you have a lot more thickening of fibrous tissue on that pleura that's normal. So maybe this is an adhesion now between the visceral pleura of the lung and the parietal pleura of the chest wall. The one thing that proves that theory is that if you go a little bit deeper beyond this portion of the fibrous tissue, you are now seeing another type of connective tissue down here. And I'm going to blow it up for you. What is this, folks? What kind of cells are these that you're seeing here? 100% of these cells, what are they? Yeah, this is skeletal muscle. I bet you if we looked around, we could even see some striations on it, and certainly the nuclei are at the periphery. So why would you have striated muscle in direct fibrous contact with lung? Well, the reason for that is you got your skeletal muscle here, intercostal muscles. You got the parietal pleura overlying it. Then you have a direct connection with the visceral pleura. This is why when you dissected through your lungs last year in your anatomy lab, you had a hard time removing the lungs because maybe the patient had a previous inflammatory process like pneumonia or TB or any inflammation, could end with a fibrous process. And now you can't easily separate or yank the lungs out of that thoracic cavity because they are plastered to the muscles of the ribs, aren't they? Okay, let's go to the next one. By the way, am I going too fast? I don't want you to feel rushed, and I don't want to feel rushed either. And guess what? I didn't realize it, but we've gone way beyond our limit. We're having so much fun. So I don't think there's anything more to show you. Some of these are, fungal pneumonias, and we talked about those, and I don't think we missed anything drastically. So thanks for sticking around. I didn't realize we were here so late. Might as well close off now, and I'm a little embarrassed that I kept you so long because I know you're working hard. You probably have other things to do. So we'll close off with a song that was submitted to us by one of our students, and I'll try to pronounce it. It's not in English. It's called Giazzotto Adagio, and we will see you in 46 hours, you buzzards. Rock on. Rock on, you buzzards.